So this patient's going to get a Toric IOL. Look a little toward my side. Good. And this toric axis marker has been set at 130 degrees. The 90 degree are very visible. So if I line those up with the corneal marks, then we're going to be having an axis at 130 degrees. So there's our 130 degree axis. And we're going to make our side port incision. I don't want to really make it exactly there, just in case. What if I couldn't put a toric in? I want to do LRIs. Unlikely. But in this right eye, I'll take the sharp side of the blade and place it superiorly, and I'll make my opening right there. And then about 2 clock hours from that, I'll make my primary 2.4 millimeter opening, stabilizing the globe with my index finger, advancing till the line is just at the epithelium, and then dimple down and enter. Okay, next comes intraocular lidocaine, and here it's a good time to tell the patient the following. You're going to feel a little sting for a few seconds, because it does. I'll also put a little bit right on the surface. Next step, I'm going to fill the anterior chamber with viscoat. And then I'm going to put some Proviskin underneath that. If I see a bubble coming out, I'll just back up and then inject it. And then I'm going to open the anterior capsule centrally. Okay. Now, a big reason you want to be able to use 2 hands during a capsulorhexis is right here. I want to center this eye. I want you to look a little toward my side. Good. And now I can keep this eye wherever I want just by doing that. And wet the cornea, please. And wetting the cornea, those little epithelial stria will not be bothering me. I like to zoom in, focus. And I'm going to grab one side of that capsulorhexis, and I'll start to tear around that way. And we're going to aim for a capsulorhexis that's somewhere between 4.5 and 5 millimeters. And basically what I'm doing is I follow the curve of the pupillary margin. And there we go. Now the next step is going to be hydrodissection. And I'm going to use this flat 23 gauge hydrodissection cannula. Put it in cortex, go out in the periphery, lift up, and inject. I'm going to do that on each side. And then we're going to do viscodissection using the remaining viscoat for 180 degrees. And that fills out the capsular fornix with the retentive, so-called dispersive viscoelastic. Testing infusion. Now here I'm going to be doing phaco chop. So I'm going to put the chopper right at the puncture site, and then just with my foot pedal in position 1, so I have resistance. Now, right away, I kind of see that I've got some ballooning of the conjunctiva there. And so what I'm going to do is take the side port blade and just nick it. Because if I proceed, what I'll probably have here is a fair amount of, I'm just nicking the conjunctiva there. And I'll do the same thing on the other side. I'd have a fair amount of chemosis, fluid accumulation, and that could actually interfere with my visibility. Okay, so let's just see that we've done that adequately. And, you know, just winging it so that the fluid won't run underneath the conjunctiva. And we'll test that again real quick as soon as we get in. Go. Yeah, that looks now like the fluid won't accumulate underneath. So position 1, pop in and right back where we were. And wet the cornea. Okay, so phaco chop, very different than divide and conquer. I like to put the chopper out over the equator and hold the nucleus nice and still. And when you have a nucleus of significant density as this one is, you'll need a fairly deep bowl in the middle, wet the cornea, to be able to chop it. And by a fairly deep bowl, I mean deep enough to get a red reflex there. I would say this is the most critical part of the procedure, because once you get that red reflex there, you can divide it. But prematurely attempting to divide it before you get that red reflex in the middle in a fairly dense lens, it won't work. Quadrant removal. So that little piece of nucleus was free, so I just took it out. See the bimanual rotation maneuver? Very nice. And one of the downsides of the divide and conquer method is that you don't have a chopper that you can put out over the equator like that and spin the nucleus. So it's a little less zonule friendly, I should say, divide and conquer. So here we are still at quadrant removal, which means you could see the parameters on the screen, about 42 cc's a minute, somewhere in the 40s. A vacuum level, I'm using very high vacuum. But any vacuum above about 350 would be comparable. But in a dense lens, if you can go up a little bit higher on that vacuum, see how I can hold it and move it around? It won't slip off very easily. And it'll hold on the tip better as ultrasound is applied. So let's just see what we have here. A little more than a quadrant. Looks like they might be stuck together, those two quadrants. But the chamber is so deep you can appreciate it in 3D. That I'm just far from the endothelium. And that's, of course, what you always want to be. And notice where the chopper is. Posterior to the fragments in the ultrasonic tip. So there's no way the posterior capsule can get up to where I am. A couple of little fragments there, I just kind of aspirated them. So the posterior capsule is protected. And as soon as you have exposed posterior capsule, you really want to do that. So now we're up to INA. Irrigation aspiration of lens cortex. There are a number of different INA tips. Some people like to use bimanual. Now I'm testing infusion capacity, and you can see it's very meager. Watch what happens when I rotate the sleeve. Yeah, so you always want to get that good infusion capacity, whether it be with the phaco or the INA tip before you go in. So now I'm on infusion, foot pedal position 2, inserted and remove cortex. So this particular INA tip that I favor is a 0.25 port rather than the standard 0.3, and it's a 90-degree angulated, but different strokes for different folks. Some people like straight tips. It makes it considerably more difficult to get subincisional cortex, as you can see me doing there. And some like 45-degree tips. And you can use polymer sleeves that protect the port and make it harder to break the capsule. Polymer sleeves, however, cannot be bent to 90 degrees. So here I'm vacuuming the undersurface of the anterior capsule, removing the epithelium, and this does two things. It prevents capsular contraction syndrome. Not that it's a very common syndrome, especially with acrylic lenses. And it also makes it easier to exchange an IOL for quite a long period of time. I would estimate to be at least 6 months and probably closer to a year or two, should it be necessary for some reason to change an intraocular lens. So now I'm injecting more Provisc. I was just rubbing the posterior capsule. There are a few little opacities there, but nothing of any visual significance prior to intraocular lens insertion. Now here we have a Toric IOL, and I'm going to be placing it at that 130 degree axis. So I'm going to use the spatula to position the globe and then just twist back and forth until I get the cartridge tip seated. And now I'll typically have the incision irrigated. So I'm sorry, the surface of the eye irrigated. So please wet the cornea, because the stria become less obvious and I can see better as I inject the IOL into the capsular sac. And then as soon as it's clear, I have palmed the instrument in my left hand. I'll come in and use that and take the trailing optic haptic and tuck that down into the capsular sac. Soon I'll be rotating the IOL into the correct axis, but for now I'll leave it, as you can see, somewhere around 45 degrees shy of the final desired resting position while I remove OVD. So you're going to feel a lot of water on your eye. And I'm going to remove OVD first from behind. And that's considered to be an important step in Toric IOLs, because if you don't remove it from behind, then it's probably more likely to have undesirable postoperative rotation. And then from in front of. Now, you can see that this haptic hasn't released. So there are a couple of ways to release it. One would be to come out and just grasp that terminal bulb with forceps. The other would be to nudge this IOL into a different position, fixate one end of it, and then just push on the haptic like so. Okay, so now I'm going to just dial this IOL into the final desired resting position. And that's going to be done with the spatula at the haptic optic junction. Now, Toric IOLs need not be precisely placed on those two lines. They can either be placed on the two lines or parallel to it. So let's see what we wind up here. And here it's gone a little bit too far past it, so I'm going to just nudge it backward. And now let's look and see. So you can see when I line the globe up, so I'm kind of looking right down the chute, that those lines on the optic, wet the cornea please, are slightly above, just slightly, but parallel to these two lines. And that's just fine. Maybe I'll back it up just another couple of degrees, ever so slightly. Yeah, good. So now we're perfectly parallel to it. And this is a myopic eye with an axial length that's around over 27 millimeters. The IOL power here is 9.5 diopters. I like the small capsulorhexis because there's probably some resistance to rotation by the capsule, actually anterior capsule contacting the anterior optic. And of course we want this IOL to remain exactly where it is. Now I'm just irrigating the chamber angle to get out the last OVD. So there are some interesting aspects to this procedure. A little bit of conjunctival fluid. We prevented that by making little wings on the conjunctiva there at the edges of the incision. And positioning of a Toric IOL. Phaco chop stuff. A good case with a lot of nice things. Looks just great now. We're done.